sick kid Toronto, so and with her mentors and learn a lot of new methods and to treat the patient with the craniosynostosis. So today is Professor Lu will give us a new guideline in this treatment. So let's welcome Professor Lu, please.
So hi everyone. Today I'm going to review with you about the updated guideline for craniosynostosis. Because of time limited, today I will only review the guideline for non-syndromic ones. Yeah. So this is the paper published this year on the Journal of Craniofacial Surgery from the Dutch group working for the guidelines of the craniosynostosis. This article is open access. You can download free from the internet. There are 17 chapters. So today I'm going to focus on the non-syndromic ones. This guideline is based on evidence from published scientific research. They searched from mainline EM-based and Cochrane library. Searches were limited to Dutch, English, and French languages. The selected articles were assessed on methodological quality graded by level of evidence according to the standard classification. The scientific evidence was briefly summarized in a conclusion. So you can see the conclusion like level 1 to level 4. Other aspects than scientific evidence may be relevant to make a recommendation as well, such as patients' preferences. The recommendation results from the combination of the available evidence and the other considerations. So today I will go through from chapter 5, the surgical treatment of isolated non-syndromic craniosynostosis. Today I'm not intending to introduce to you about craniosynostosis. So the basic knowledge will not be discussed today. We just go through the evidence about the surgical indication, surgical methods, surgical timing, and follow-up. The 4 basic types of non-syndromic craniosynostosis is sagittal, metopic, unicoronal, and unilateral lumboid. The metopic craniosynostosis is spatial among those 4 types of craniosynostosis. Due to its classification, it's not very clear. The shape of trigonocephaly can be classified as severe form, moderate form, or mild form. The severe form has the most prominent part of the forehead in the midline of the forehead. Lateral orbital ring clearly visible. So you can see from the pictures I demonstrate on the left is the severe form. So the moderate form has the most prominent part of the forehead lies between the medial parts of both eyebrow. Lateral orbital ring are either just or not visible. Mild form, you cannot see the lateral orbital ring. So I demonstrate the other pictures. I think it's a moderate form. Actually, the surgical indication is not very clear for metopic synostosis. The concluded surgical indication is level 2 evidence that only for the most distinct form of metopic is the indication for surgical correction. The mild form, the chance of spontaneous recovery is high in contrast to the severe type of trigonocephaly. No recommendation is given for children with moderate trigonocephaly. Because they found whether surgery is associated with gains in neurocognitive has not yet been determined, even for the extreme presentation. According to the working group, most parents of the children with the metopic suture synostosis, they found the aesthetic outcome, neurocognitive function, and sight crucial outcome measures. So they therefore they agree with a surgical treatment. Only surgery can improve the aesthetic aspect and reduce neurocognitive deficit and vision problems. For the metopic ridge, that does not apply because of spontaneous recovery of the head shape. For the mild and moderate form of trigonocephaly, this is not so certain given the dependence of the definition used. So how about the surgical methods? There's only one level 3 evidence shows that minimally invasive surgery is likely to result in less blood loss, fewer blood transfusion, shorter surgical time, and shorter duration of hospitalization. Minimally invasive surgery for metopic suture synostosis may have the same aesthetic result as open cranial correction. However, those evidence were weak evidence because most studies have a non-comparative group. The reoperation rate are 25% for the minimally invasive technique versus 3.8% for open. So based on those evidence, there's no recommendation is given regarding to the surgical technique. How about the surgical timing? Considering the low prevalence of papillary edema in metopic suture synostosis during the first year of life, there seems to be no compelling reason to perform the operation before the age of 6 months. So there's no recommendations given regarding to the timing of the surgery. For the follow-up of the metopic craniosynostosis, routine fundoscope in metopic suture synostosis does not seem to be indicated as the prevalence of the papillary edema is very low. So you can only do like annually do the measurement of the head circumferences. If the growth curve deflated, fundoscopy and OCT is still indicated. I have few cases of metopic synostosis. From the definition, I think this case is a moderate to severe form. The prominent ridge between the eyebrow, from the top, you could see the lateral orbital ring. We did the frontal orbital advancement for him. So this is the 6 months follow-up. Although I put almost like 1 centimeter bone graft in the middle, it seems still not enough wide. So this is my latest case with the metopic, looks like a moderate form. I did an even wider bone graft in the middle. I hope it will have a better result. So we use in-house surgical simulation for the reconstruction for the forehead. Traditionally, the reconstruction should be based on surgeon's experience or what they learned. However, in this case, I found the shape of the bone cannot be fit according to what I learned before. So luckily, we have a plan before the surgery and we did the bone cut and reconstruction according to the plan. So it was really fit. For sagittal cranial synostosis, expert opinion is surgical treatment for the sagittal synostosis is indicated since there's no spontaneous improvement of the abnormal skull shape is expected. So how about the minimally invasive surgery for or open cranial correction? Level 2 evidence shows minimally invasive surgery is likely associated with significant less blood loss, fewer blood transfusions, shorter surgical time, and shorter duration of hospitalization with a similar aesthetic result compared with open cranial correction. The decision for the type of minimally invasive surgery depends on surgeons' preferences and experience. The evidence only provide comparable result between the minimally invasive or open cranial valve in the short term, like 1 year follow-up, The long term, like 5 years, is unclear. So the relations between the neurocognitive and visual result of the two techniques is not very clear. So the minimal invasive surgery after the age of 6 months is less effective than before that age because increased ossification makes the skull less deformable. And extensive open cranial correction before the age of 6 months seems to induce a growth limitation of the skull and is therefore mainly performed after that age. So they recommendate if the patient comes earlier, like younger than 5.5 months at referral, you can do the minimal invasive surgery. However, if the patient come later than like 6 months, you can do the open cranial correction. So how about the timing of the surgery? The prevalence of papillary edema in sagittal suture synostosis is likely to increase during the second half of the first year of life, and therefore surgery before the age of 6 months is recommended. However, the outcome of the prevalence of a papillary edema in the first year of life is supported by weak evidence. The only clear indication for early treatment is the increasing prevalence of papillary edema in sagittal suture synostosis. So for the other 3 types of craniosynostosis, there's no definite reason to give a timing recommendation at this moment. So for the sagittal synostosis, correct, if possible, sagittal suture synostosis before the age of 6 months. For the screening for the increased intracranial pressure, screen annually for increased intracranial pressure in patients with sagittal suture synostosis by fundoscopy or by OCT during follow-up until the age of 6 years. They found that the children with a sagittal suture synostosis, they have a higher prevalence of increased intracranial pressure between age 3 and to age 6 years. So you usually should follow up this patient up to the age of 9. And screening for sagittal suture synostosis is carried out until the age of 6 years. And after that, only on indications to do the fundoscopy, as the prevalence decreased considerably after that age. I have 3 experience of endoscopic straight craniotomy for sagittal craniosynostosis. So the first 2 cases, they were found very early in life. We did surgery around the age of 2 months old. So you can see the follow-up picture, they are almost like 2-year-old. The patient, the boy didn't wear the helmet after the surgery. However, you can see a very good head shape after 2 years. So that's my second case of the endoscopic straight craniotomy. We also performed the surgery at the age of like 2 months old. So the follow-up picture is almost like 1.5 year old. So you can find the head shape is very good. So the patient, he didn't wear a helmet either in this case. We remove about 5 centimeter bone in the sagittal suture and wedge over the parietal bone area. So this case is my 3rd case of the endoscopic straight craniotomy. He comes relatively late, around 5.5 months old. So after the surgery, he wear the helmet. So far, after 1 year, he wear about like three helmets. So you can find the improvement of the head shape, but not like as good as the previous one. So I think if you can do an earlier surgery, you probably do not need the helmet to shape the head. So after 6 months, I did the cranial valve reconstruction for the sagittal, like this boy who comes around like 1 year, around 1 year. So we did the surgery around like 1 year. We do the total cranial valve reconstruction. This case, we did the surgery around, he comes even later, like 1.5 year. So we do the total cranial valve reconstruction. And this boy who comes even later, he comes like 4 years old. So we also do the total cranial valve reconstruction. If the patient comes earlier, I prefer to do only the posterior valve reconstruction. Like this boy, we did the surgery around like 10 months old. So the following I'm going to talking about the unicoronal craniosynostosis. In the surgical indication for the unicoronal synostosis is based on experts' opinion. No spontaneous improvement of the abnormal skull shape is expected. So only surgery can improve the aesthetic aspect and reduce neurocognitive deficit and vision problems. So how about the minimally invasive surgery or open cranial correction? The risk of papilledema in a 6-year follow-up period after open cranial correction is possibly very low. The arithmetic outcome of minimal invasive surgery may be superior to those of late open cranial correction or may have the same aesthetic result. However, the evidence is weak. Therefore, there's no recommendation is given regarding to the surgical technique. 6-year follow-up result of frontal-orbital remodeling in 207 patients with coronal suture synostosis shows that there's no operations were necessary because of elevated intracranial pressure. Supraorbital retrusion and temporal hollowing were particularly seen 5 years or more postoperatively. Therefore, long-term studies are required to assess the ultimate outcome. So there's no recommendations given regarding to the surgical technique. So, sorry. So how about the timing of the surgery? There's no recommendations given regarding to the timing of surgery. Frontal-orbital advancement is technically more difficult for the age from 6 to 9 months old, as the ossification of this bone is still limited. So usually the frontal-orbital advancement is done later after 9 months old. Sorry. So screening for the increased intracranial pressure for the unicoronal craniosynostosis is the measurement of the head circumferences. If the growth curve deflected, fundoscopy and or OCT is still indicated. I have never tried a minimal invasive surgery for the unicoronal synostosis. I did the frontal orbital advancement. So that's the example of the unicoronal craniosynostosis with the frontal orbital advancement. So you can see from the two cases, if you planned with the computer-aided simulation, you could find the puzzle of the forehead shape is quite simple. So you don't need to cut many pieces to make a good shape of the forehead. So that's the other case example. I did the same technique and also the same cutting methods for this case. I found there seems there's a lure for the unicoronal synostosis for the reconstruction. For the lomboid suture synostosis, the surgical indication is the same as sagittal and unicoronal. It's based on expert opinion. And the surgery is all indicated due to there's no spontaneous improvement of the skull shape can be noted. For the minimally invasive surgery or open cranial correction, minimally invasive surgery may give the same aesthetic result as open cranial correction for lomboid suture synostosis. However, this is based on weak evidence. No recommendation is given regarding to the surgical technique. So for the timing of the surgery, there's no recommendation regarding to the timing of the surgery. Screen annually for increased ICP by measurement of the head circumferences. If the growth curve deflected, fundoscopy or OCT is still indicated. Because lomboid suture craniosynostosis affect the skull shape from the skull base to the whole skull, I think the reconstruction is quite difficult, and I think there's no rules for the reconstruction. So I cut several strips and try to adjust the shape of the bone to make the skull more symmetrical. I think it is very, which is nearly impossible. However, in this case, he achieved a relatively good result. This boy received strip craniectomy at the other hospital at the age about 4 months old. Of course, you can see the scar is not minimally invasive, but it's a strip craniectomy. After the surgery, he wear a helmet to correct the shape. So as you can see from the pictures, he has wear 11 helmets to correct the shape. So of course, the patient got a fair result after 2 years with the helmet. Because the parents, they are still not satisfied with head shape, I suggest the parents to redo the surgery after 11 helmets. And also, we did an MRI before the surgery, and we found there's a Chiari malformation. Therefore, with posterior valve expansion and reshaping, plus a bony decompression on the foramen magnum. So like the previous case, we did a multiple cut, strip cut on the posterior cranial valve and reshaped the bone according to the guide. So the rest of the speech, I'm going to go briefly through some important topic in the guidelines. The chapter 8 is about the increased intracranial pressure over the craniosynostosis. So on the table, you could find the incidence of the increased intracranial pressure in different type of craniosynostosis. So the other table there show an incidence post-operatively. Preoperatively, the incidence of increased intracranial pressure in sagittal is ranged from 2.5 to 14 and increase with age. For the metopic, it ranged from 2 to 8%, and for unicoronal, it is around 16%. So after surgical correction, the incidence for sagittal is 2 to 9%. Metopic is so the metopic is around 1.5%. There are 6 diagnosis tools could possibly be used, except for the direct ICP monitor, such as the head circumferences, growth curve, the presence or absence of diffuse depression, like you can call it like Cooper-Beaton sign or thumbprinting sign, detected by the skull X-ray. The presence or absence of additional coronal suture fusion detected by X-ray or CT, or you could do the optic nerve ultrasound, or you could use a fundoscopy to find the evidence of papillary edema, or also the optical coherence tomography, which is called the OCT. So in the previous chapter, I have been described about the annually screening ICP in different type of craniosynostosis. However, there's some conclusion which is very interesting and important. Like you can see from the table on the left, on the bottom. So the presence or absence of diffuse impression on X-rays in children under 18 months may be an unreliable screening methods for increased intracranial pressure because the sensitivity is 0%, but the specificity is 95%. For the children aged 18 months to 4 years, the sensitivity was 64% and the specificity is 50%. So making it a reasonably reliable screening methods. So you can look at the table on the right, on the bottom. The ultrasound measurement of the thickness of the optic nerve does not appear to be a reliable screening methods because it has a very low sensitivity. It's like 11%. There's another evidence like presents coronal suture fusion on X-ray or CT in children with sagittal suture synostosis younger than 2 years after surgical correction. It may be a potentially relative risk factor for increased intracranial pressure. So papillary edema found in fundoscopy, its absence does not rule out increased intracranial pressure in children under 8 years of age. And the OCT is probably a reliable method for screening for intracranial pressure, but requires patient cooperation because there's a machine to do the OCT. The sensitivity of OCT to predict papillary edema is 60% and the specificity is 90%. The sensitivity of OCT to invasive ICP measurement is 89% and the specificity is 62%. So conclude that actually I have mentioned previously, like for the metopic suture synostosis, you just need to circumferences. For the sagittal suture or syndromic patients, you should do fundoscopy annually, or you could do the OCT if the children, they are capable of being instructed. The fundoscopy beneficial is very low in metopic and non-syndromic unicoronal synostosis. So the chapter 10 is talking about Chiari malformation, which I feel it is also important. The symptoms of the Chiari is not specific. but may be critical. The prevalence of Chiari is around 3 to 8% for sagittal, 0% for metopic, 6 to 18% for coronal, and 25 to 60% for lumboid. And usually the Chiari is asymptomatic below the age of 18. So you can only be diagnosed by screening with MRI. So they have a recommendation for screening and follow-up. Like for the single suture, you should do MRI for the unilumboid suture synostosis before the surgery, or multi-suture synostosis with involvement of the lumboid suture, or and also cruzones and fiber. And you should repeat the MRI at the age of 4-year-old and also at the age of 18-year-old, because they found that below 18 years old, there's almost no symptoms. And also you should consider a cervical, thoracic, or lumbar spinal cord for the presence of a syrinx if the Chiari increased or become symptomatic. And perform the surgical treatment of Chiari only if the patient has symptoms. And of course, refer this patient to the neurologist, the neurosurgeons, to follow up these patients. So chapter 11 is talking about the visual, refractory, and motility impairment. Loss of vision in craniosynostosis is caused by optic atrophy secondary to papilledema in elevated ICP, primary optician atrophy, coronal abnormalities by longophthalmus, or amblyopia secondary to strabismus or refractive abnormality. So you should recognize that, and treatments are essential for vision retention. So I'm not going to focus on this chapter, but we have to remember that if there's a suspicious, you should refer this patient to the ophthalmologist. Screening this patient for metopic suture synostosis and unicoronal synostosis, and also of course the multi-suture and syndromic cases. The chapter 13 is talking about the hearing impairments and speech and language development. About the hearing loss, they are almost in syndromic patients, so I'm going to skip this part. For the speech and language, how about the speech and language about the study? So you can find that the single suture craniosynostosis age 6 to 18 months appear to have a slightly increased risk of speech and language problems compared to those patients without craniofacial anomalies. The children with a metopic lumboid or coronal suture synostosis age 6 to 18 months appear to have a slightly increased risk of speech and language delay compared to those children without craniofacial anomalies. How about the children at the age of like 3-year-old? They found that the single suture craniosynostosis at the age of 36 months probably have a slightly to moderately increased risk of speech and language problems. Metopic suture synostosis may have an increased risk compared to the children with a sagittal synostosis. And if the children have a unicoronal or lomboid, they have an increased risk of speech compared to the children with sagittal. At the age of 7, they found at the age of 7, they are to have a little or no increased risk of speech or language problems. The other evidence shows they probably have a slightly increased risk. The children with the metopic suture synostosis may have a slightly higher risk. Also, the unilateral lomboid or coronal suture compared to the children with the sagittal. So based on the result of the literature review, distinctions made between the children with sagittal or metopic suture and the children with coronal or lomboid suture. And they found that the children with coronal or lomboid suture synostosis have a higher risk of speech and language problem from 36 months onward. So they recommend the patient, if you find there's a speech or language problem, you should refer them to do the screaming instrument like FAST. Chapter 15 is a neurocognitive, social, emotional, and behavior functionally. Actually, for the developmental problem, they found there's for the single sutures craniosynostosis, they probably have a significantly higher prevalence of development delay than in the control group. Also, the IQ are common, lower IQ are common in children with a metopic suture, coronal suture, and lomboid suture. For the behavior, they found that children with a metopic suture synostosis have the most behavior problems. The children with a sagittal synostosis has the least. For the executive functionally and memory at the age of 18 months, they may score the same compared to the control group. For the age of 7 years, they may score significantly lower on the text investigating inhibition and distributed attention than the children in the control group. For the cognitive function and school skills at age of 7, they may be similar to the normal people. On the numerical test, they probably have a score significantly lower. Okay, so if you are interested, you can read the guideline more clearly on the guideline. So at the age of like 4 to 5 year old, if the patient has a concern, they have probably a delay on the neurocognitive function, you should refer this patient to the specialist. So the rest of the last on the guideline, they have a flow chart. So you may go through this. Okay, so that's the end of my speech. Thank you very much.
Hey, thank you, Professor Lu, for your updating in the treatment of synostosis. We are welcome for all the questions from our audience. However, first of all, I have one question for Professor Lu, is that I think in my experienced for some symmetric deformity, just like the sagittal, metopic, like that. Probably we just only to focus on the reduce the length or to make a more symmetric result. However, I look at one of your case of the unicornular cases. So would you like to do or design a little bit the overcorrection for the lesion side for the futures that maybe it will show some asymmetry? So I just wondering how about your design for the unilaterals, the asymmetry cases?
I think there are different opinion on the overcorrection of the unicornular synostosis. What I learned in CK's hospital, they don't prefer an overcorrection on the bone. So actually, I don't do the overcorrection. I just try to do a symmetric forehead on the bone shape. But of course, I don't have a long-term follow-up for these cases. But I think different surgeons, they have different opinion on the design.
Yes, I think so. Okay, so we have one question now. Dr. Mumbai is asking, what is the role of the distractions versus the surgical advancement in the treatment? The distraction and the surgical advancement.
Distraction. You mean use the distractor?
Yeah, maybe for the posterior valve distractor or the one-time remodeling surgery. I think this is a question. Maybe the posterior is the distraction to make the posterior elongated of the head shape and the surgical advancement only.
Actually, I only do the distractor. We have a distractor in Taiwan, and we do the distraction for the syndromic cases or like a brachyterocephaly, like APERS patients with a bicoronal suture synostosis. I will do the posterior distraction. Of course, I know there's a lot of places the surgeons, they are really innovated. They will do like FOA, use the distractor, or use the unicoronal using the distractor, but I don't have the experiences. I only have a posterior valve distraction, and I found the result is very good. I would really recommend the distractor for the like syndromic cases for earlier surgery.
Okay.
I don't know if it answered the question.
Yeah.
Like this case, sorry, I didn't prepare well for the slide. So this is the case we use the distractor for the APERS patients. We put 2 distractor on both sides, and I think that's a very good method for the head shape.
Okay. So I have one more questions for that is I think it's always be asked by the parents. So early surgery and the delayed surgery, and what is the influence by the patient's the IQ? What is your opinion, Professor Lu?
I think from the guidelines we read through today, there's only evidence for the sagittal, like this slide. Like this one. So go through this 4 type of single suture craniosynostosis. There's only evidence for sagittal suture craniosynostosis you should do earlier surgery. So they recommend, if possible, you should do the surgery before the age of 6 months. I think there are several papers talking about, mention about the IQ compared to different type of surgery, like open total cranial valve, or you do like a spring, or you do endoscopic strip craniotomy. So they found if you can do earlier surgery and bigger surgery, you possibly can get a better IQ for these patients. But I think from this guy, like they just mention about if you could possibly do earlier, you should do the surgery before the age of 6 months. But of course, if you consider the ossification of the bone, if you want to do the open cranial valve, the total cranial valve reconstruction, you should do the surgery after 6 months for the better bone qualities.
Okay.
But yeah, but for the other type of the single suture craniosynostosis, there's very low chance of papillary edema before the age of 1 year old. So they don't have a recommendation on the surgical timing, because they probably there's no difference if you do earlier or late about the IQ of the patients.
Okay, so we have the next questions. Professor Lu, which would be your best indications for using the pre-op planning and the CAD/CAM to guide the surgery, or using the CAD/CAM is your routine? So what is your best indication?
Actually, we do in-house simulation. We have an engineer who designed the surgical, the planning. So in every case, we do the surgical planning. And actually, it takes only like 2 days, I think. And we have very good communications between me and the engineer. So there's only 2 days. I think it's quite easy for him. And we are going to, I think they have our engineer, they have invented some kind of like AR, they
Yes.
augmented reality methods to simulation the surgery. Maybe next time we can talking about this.
Yes, very good. Because the last time I have ever to seen the surgeon using the automated reality to wear a glasses and to perform the wedge osteotomy and reestablish all the bones in it by his design. So I think it's very efficient, and I think it's a little bit precisely.
Yeah.
Yes. Okay. Okay. So any questions from the audience? Okay, so if there is no question, I have only one last question to ask. I have no idea about the ultrasound to determine the intracranial pressure. So, is this a traditional method, or it is already not applicable to be used to determine the intracranial pressures?
This one. So actually, on the brain echo, they can find the blood flow in the brain. So actually, it may detect the increased intracranial pressure. However, it usually is applied to acute trauma. If the children had an acute trauma, they can do the brain echo, and if they found there's an increased intracranial pressure, they can do the surgery, like emergency surgery. However, for the craniosynostosis, we concerned about the long-term effect of the intracranial pressure. So if you see from this guidelines, they provide only 6 methods that possibly can predict the increased intracranial pressure, except for you put directly the ICP monitor on the brain, right?
Mhm.
So I think they found there's, like you can see from the slide, the optic nerve ultrasound. They found the evidence there's only like 11 sensitivity.
Mhm.
So actually when I try to, because we have a pediatrician who can do the optic nerve ultrasound to measure the optic sheath thickness. However, because the sensitivity is quite low, so I think that's not a good method to predict the intracranial pressure.
Mhm.
Right now, I think everybody can accept that to do the like fundoscopy to detect the papillary edema. It probably is easier way and correct way to predict the intracranial pressure.
Mhm.
So I think that's a very good guideline we
Mhm.
read from this article, because we should know like which evidence we should use to detect the intracranial pressure. For the optical coherence tomography, I think that's the recently evidence to detect the intracranial pressure. However, the patient should be like more than 4 years old to cooperate with the
Mhm.
machine. So I
Yes.
think that's a very sensitive and specific way to detect.
Mhm. Okay. Yeah. Okay. 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 One more question, sir. Uh, could you also give us any advice to prevent the temporal depressions that may be developed in the long-term follow-up of some patient with the FOA? Yes. Any advice to prevent the temporal depression?
I think that's a difficult questions, because nearly every patient has a temporal howling after the FOA. I think because we detach the temporal muscle from the skull bone. I think that's the reason. I'm not sure if you do a very good like retach the muscle to the to the to the bone, can prevent further howling, but I would like to know the answer. I'm not really sure.
Mhm. Okay. So if there is no more questions, I would like to say thank you, Professor Lu. Today's the presentations about the updating treatment in the synostosis patients. Thank you very much. Yeah, and we are looking forward to your more experience in the future. Yes, and I have to announce our next webinar 2 weeks later. 2 weeks later, the 2nd of the May, we invited Professor Hong Chen. Hong Chen is one of our members in the team of general plastic, and he would like to share his experience in treating the patient blepharoplasty lower, and that is the new published. He will show the 4 different kind of the method in this kind of patients. So thank you, Professor Lu, again, and thank you all of the members in our webinar. And good day and good night. See you next time. Bye bye. 谢谢哦。谢谢。